Chair Murray, Senator Cassidy, and distinguished members of the Senate Health Committee, thank you for the opportunity today to talk about these grave matters that weigh heavy on my heart. As described, I'm Josh Corman. I'm the founder of a volunteer grassroots group of hackers trying to save lives through security research. In recognition the cavalry isn't coming, we asked, what are you willing and able to do? Will you be part of that solution? Will you be a voice of reason, technical literacy, and a helping hand to work with policymakers such as yourselves to make things safer? Our problem statement was simple. Our dependence on connected technology was growing faster than our ability to secure it in areas affecting public safety, human life, and national security. What we were doing 9 years ago was trying to build the trust and the foundation so that we could prevent loss of life. There was a promise in a peril to connected technology. We always adopt things for their immediate and obvious benefits. We have a very hard time determining the delayed consequences of those choices. And I warned the teams, people would have to die first before anyone would listen to us. To our delight and surprise, bravery from Dr. Suzanne Schwartz at FDA took bold action to try to make sure we raised the bar for minimum cybersecurity hygiene for medical devices and issued the first ever safety communication for a medical device purely for cybersecurity reasons, and no one had died. They'd sent a shot over the bow to the industry of 10,000 medical device makers that the dependence we place on connected technology should be worthy of that trust. These are devices like this little pacemaker, some of which have found a hard-coded 3-digit password is sufficient to affect the hearts and functions of 750,000 patients. We have similarly compromised insulin pumps to give a second lethal dose of insulin without authentication, found by a diabetic himself. We have found bedside infusion pumps that should deliver a 3-hour dose of a calcium channel blocker, could empty the contents in 30 seconds. And we've done these through clinical ER hacking simulations in consultation and collaboration with federal agencies, with medical practitioners, with physicians to see, can we handle these disruptions to the technologies we take for granted? Through that work, I got to serve on the 2015 405C Congressional Task Force on Healthcare Industry Cybersecurity, and because of the trust built there when the country and the world faced the pandemic of the COVID-19 virus, Director Krebs, using the CARES Act hiring authority, asked me to serve my country and design and implement what became the CISA COVID Task Force. Senator Cassidy, that report that you referred to, we looked harder and closer at the nation's ability to provide medical care than anyone had before, and armed with the extreme pressures and strains of the pandemic, we could use data science to calculate how ICU strain dramatically caused loss of human life. We found that if the country's ICU beds hit 75%, you would see 18,000 lost Americans in 2 weeks, with additional amounts 4 and 6 weeks later. And if you hit 100% ICU strain, you would see 80,000 lost Americans. And unlike the losses to COVID, these were 25 to 44-year-olds primarily. So the question became, can these cybersecurity failures affect patient care and human life? And we were able to determine the answer was yes. Delays in degraded care affect mortality rates. A seminal New England Journal of Medicine article showed that a 4.4-minute longer ambulance ride during a US marathon had a statistically significant impact on mortality rates 30 days later. Similarly with strokes, the golden hour or golden hours is 1, 3, or 4 hours can affect patient care if you can walk again, if you can talk again. So if 4.4 minutes can affect the mortality for heart, and 4 hours is the difference between life and death for brain, what do 4 weeks of downtime for the state of Vermont, or for the protracted impacts to Scripps healthcare in San Diego? These failures further strained already record-strained healthcare delivery, introducing a loss of life, not just of elderly with 65 years or 4 or more comorbidities, but critical infrastructure age workforce that we depend upon. And in parallel with these record high strains, as these losses of life succumb to COVID, non-COVID conditions, injury, burnout, retirement, and alterations to their family support structure. If we zoom out to Maslow's hierarchy of needs, in the last 2 years, we have seen successful compromises of the water we drink, the food we put on our table, the oil and gas that fuels our cars and our homes, the schools our children attend, the municipalities who run our towns and our cities, the timely access to patient care. During a pandemic, I myself suffered degraded and delayed care, which imperiled my ability to serve the country during these 2 years. We are over-dependent on undependable things, and while we are doing many correct things, and this body themselves has taken bold action, these voluntary practices where we take our time have not proven sufficient to transcend the market failures. The adversaries are setting the pace. We are messing with Maslow. It is not tenable for an individual nor a nation. And with the threats of further attacks from Putin and other nation-state adversaries, we need bold action, and we need it now. Any crisis of confidence in the public to trust these baseline functions is unacceptable. We need to be better. We have a head start. I have in my testimony areas where we can stem the bleeding in the foreseeable future, but we'll take much more substantive action. I look forward to answering your questions.
Thank you.